Now I am going to talk on hydropneumothorax, its diagnosis and management. Now, hydropneumothorax (HPT) is a condition characterized by simultaneous presence of air and fluid in the pleural space. It's commonly result from infection, trauma, or iatrogenic causes and can lead to significant respiratory distress if not managed promptly or properly. So, what is a overview and background? Hydropneumothorax is a variant of pneumothorax with a with an additional fluid component leading to a characteristic air fluid level on imaging or seen on the X-ray. It is often seen in tuberculosis patient, lung malignancy and trauma related injuries. The accumulation of fluid and air alters the pleural mechanism causing lung collapse and impaired ventilation. So, what are its causes? First is the infectious. It could be caused by tuberculosis, pneumonia, lung abscess rupture. In traumatic, penetrating chest injury, rib fracture, and in iatrogenic, post-procedural complication. So, in thoracocentesis or in mechanical ventilation. Malignant bronchogenic carcinoma, pleural metastasis. So let's discuss epidemiology. It is more common in developing countries due to high TB prevalence, seen in 5 to 10% of patients with tuberculosis pleural effusion. Can occur at any age but more common in adults with underlying lung disease. In a pathophysiology and pathogenesis, air entry or bronchopleural fistula or trauma allow air into the pleural cavity. The fluid accumulation, infection, malignancy or hemorrhage lead to effusion. Pressure changes. The air fluid interface disrupt lung expansion causing dyspnea and hypoxia. Inflammatory response. Chronic cases may develop fibrous pleural thickening, impairing lung re-expansion. And in pathology, grossly, there could be a pleural thickening, air fluid interface, collapsed lung. Microscopically, inflammatory exudate, possible malignant cell in neoplastic cases. So now let's discuss about the clinical manifestation. First is the symptoms. There could be a sudden onset of dyspnea, pleuritic chest pain, cough would be dry, fever, weight loss in infectious or in malignant cases. In signs, there is a diminished breath sound, hyperresonance over and dullness below the air fluid level, decreased chest expansion on the affected side. Now, in diagnostic evaluation, first is a imaging or radiology, chest X-ray. There is a air fluid level with a sharp horizontal or a straight line, horizontal line. Ultrasound is a procedure will confirm effusion with underlying air pockets. CT chest is supposed to be a gold standard to assess lung parenchyma and underlying pathology. In a laboratory test, pleural fluid analysis, exudative effusion, often with ADA in tuberculosis cases, high ADA, adenosine diamine amines. Microbiological study, gram stain, AFB stain, that is head and stain, gene expert for TB. So let's talk about the treatment and management. First is the supportive measures, oxygen therapy, analgesic for pain relief. Definitive treatment is a intercostal drainage, that is called ICD, to remove air and fluid. Pleurodesis if persistent fistula or malignancy related effusion. Surgery like VATS or open thoracotomy. In resistant cases or emphysema formation. Medical management. Antibiotics in infectious cases, mostly empirical or culture guided. Anti-tuberculosis therapy, that is ATT, if TB related. Chemotherapy or radiotherapy if secondary to malignancy. So, prevention and future perspective. In prevention, early diagnosis and treatment of TB, avoidance of chest trauma and iatrogenic injury, proper aseptic precaution or technique during thoracocentesis, future perspective, minimally invasive technique like VATS or fluoroscopy for better outcome. Advanced biomarkers, research for early TB detection in hydropneumothorax cases, newer treatment modalities including targeted therapy for malignancy related hydropneumothorax. So last, in a conclusion, hydropneumothorax is a potentially life-threatening condition requiring prompt urgent diagnosis and treatment with early intervention, including ICD drainage and treatment of underlying causes. Prognosis is generally favorable. Ongoing research in imaging, biomarkers, and minimally invasive approaches will further improve patient care. Thank you.